Welcome to the Wild Physio podcast with your host, Andrew Wild. Today, I'm super excited. I have Dr. Jacob Templar on, and he's a physical therapist and recreational lifter. Jacob works full-time in Rochester, New York, and is a consultant with the Strength Guys. Jacob is a board-certified orthopedic specialist and has a certification in mechanical diagnosis and therapy. Jacob had 6 years experience in outpatient orthopedics, primarily working with patients with spine-related concerns and headache and migraine conditions and persistent pain. He's also a social media meme specialist, and I love his form on social media. A huge welcome to Jacob Templar.
Yeah, thanks for having me on. I appreciate it.
My pleasure. How's everything going over there in New York?
It's good. Other than the fact that in America we do daylight savings time. So this week was like we sprung forward an hour, and so everybody's all screwed up still from that.
Yeah, and we was always going to do this podcast now, but we didn't factor in the daylight savings. It's always hard when daylight saving kicks in. So Jacob was ready an hour ago. Anyway, we're here finally.
Yeah.
Now I'm going to start this podcast with some yes or no's. All right, a bit like Oprah when she asked Lance Armstrong all the yes and no's. Are you ready?
Yeah. Yeah.
All right, let's do it. Is disc degeneration normal?
Yes.
Is flexing your spine under load okay?
Yes.
Can you have pain without tissue damage?
Yes.
Is getting an MRI usually a bad idea with people with back pain?
Yes.
Is a disc like a jelly donut?
No.
I'm loving these answers already. Are physios and other healthcare providers not very good at accurately palpating specific structures?
Yes.
Is having scoliosis and a leg length difference normal?
Yes.
Is there such thing as the perfect posture?
No.
Is telehealth consultations as a physio just as effective as face-to-face physio?
Ooh, that's a tougher one.
Yeah.
I'm gonna say yes, but I have more to say on that later.
Let's talk about that further in a second. Last one. Do biomechanics matter as much as most physios think they do?
I'd say no.
Cool. Love it. Well done. You got through it pretty easily.
Yeah, I mean, I definitely have nuanced approaches on all those, but I guess that's like if I were to say majority of the time, that's what I would say.
Yeah, sounds good. Well, let's do this. Let's peel back to each question now. The first one was, is disc degeneration normal? Let's just go through that a little bit because I find this is really frustrating. People come in and see me and they're like, oh, I've got disc degeneration. And it's kind of like this life sentence. They think that they can't do certain things because they have disc degeneration. Let's just peel that back a little bit. And why did you say it is normal?
So I say that's normal because if you look into spine literature, majority of people are going to have what appears to be degenerative changes on like an MRI or an X-ray. And I think depends on where you look, but normally it's like at the age of 60, it kind of plateaus and almost everybody has that.
Yeah, for sure. And it's really well answered. And, people as young as, in their late teens, early 20s are going to have some disc degeneration. And a lot of the time you'll see, physios, chiros, these type of people, they see that on scan and they think that that is potentially the cause of a lot of their pain. But pain is just so complex that it's often not the issue at all. And this segues into the next question that you've kind of already gone through. Can you have pain without tissue damage? And you said, yes, you can have pain without tissue damage. Can you just go into that for the listeners? Why can you have pain without tissue damage?
I mean, it's because it's a complex experience. So there's lots of pathways in which the body communicates, like what's happening environmentally within your body, things like that, where you can even see where there's some studies now where they've experimentally induced pain in people that didn't actually have any like trauma. Like you can hypnotize people into having pain. You can, there was like a few years ago now. I think it's like 3 or 4 years ago. There was this viral video that went around with a hand where they were like petting this like rubber hand, and you can experimentally induce people to have pain in their what they perceive as being their hand, but it's a rubber hand.
Right. Now, in regards to, say, for instance, someone comes in and they're like, they've got a disc bulge. They've got a disc bulge between L4, L5. They've been told by, say, another physio or a chiro and an orthopedic specialist or a doctor that that is the cause of their pain. How would you break that down for them if you thought that it wasn't necessarily the cause of their pain and there were other things going on that were, I suppose, feeding their pain cycle?
One of the things that I break down is just like, first get it to know them, like figure out kind of what makes them tick a little bit, why they're even like here to see me again, how long ago it happened, things like that, because then you steadily start to present information about how those tissues heal, maybe times that they didn't have pain in positions that like they would perceive to be bad for their discs and things like that, and then start to show them like how through activity they can do some of those things again and how those things heal very well. Like one of the things is like bringing up even anecdotal examples where I've had patients that have come to me with that diagnosis, and then say like after we're done with treatment, like I had one patient who he had what looked like a fairly large disc herniation on an MRI. And then, so we finished up treatment, and then I think it was like 6 months later or something like that. They went and saw their like an ortho specialist surgeon, and they did another repeat MRI, and there was like nothing there anymore.
Can we quickly go through that as well? So obviously a lot of people have disc-based issues and, disc bulges, disc protrusions. You hear that every day from patients. They come in and they say that they've got this, and this. Can we just go through, in terms of the discs, we can see that discs get reabsorbed in terms of the bulge or the protrusion. Just go through that a little bit with the listeners as well.
Yeah, I mean, so the whole thing is with those is that the amount, I mean, even like if you get into like biomechanical training, where I started, like you look at different types of disc bulges that we would name them in like medical talk, like protrusion versus like prolapse versus like I forget the other one because I haven't had to use them. Yes, extrusion. Yeah. And then a sequestration, which means like there's nothing holding it in anymore. Like if it were to be a balloon, the balloon's popped. But typically what a lot of the literature says is that actually the larger that is, the more likely that it is to be reabsorbed. Most people have reabsorption again within 6 to 8 weeks. Where in as little as like 2 weeks, you can see 50% reabsorption again. It's not as clear in the lower back as it is in the neck, that it's like a 50-50. If your symptoms are gone, you may see a reabsorption, versus where in the cervical spine, it seems to be more of a, if you see symptoms recede, then people's disc like tends to be reabsorbed more. And then you add on to the fact that if you look at newer literature, there's stuff from like Peter O'Sullivan's obviously really popular over where you are. And some of their stuff that he cites and he's done shows like maybe 5% of people have like back pain because of a disc herniation.
And the rest of it is coming from?
It's what we call non-specific low back pain.
Yeah, and there's so many things that can influence non-specific low back pain, as we well know. And there are things like stress, like a sleep, environmental pressures, previous experience, how they've been brought up, and their relationship to pain. There's so many factors that go into someone's cup of pain, and I often describe it like that. It's like you're filling up a glass of water or a cup of water. And there's so many things that are going into that. There is potential tissue damage. There is, as I was saying, sleep, stress, previous
Mhm.
experience, environment, anxiety, fear, worry, all these type of things do influence someone's pain. Now, we've already discussed the disc a little bit. I love the fact that you were so adamant with the fact that a disc is not like a jelly donut. You said that it definitely isn't. Let's go through that, because it kind of pisses me off that we're still at this point where people are describing discs like a jelly donut, which indicates that it's really not that strong. Because if you get a jelly
Yeah.
donut, if anyone's ever had a jelly donut, if you squeeze it, the jelly comes out pretty easily. It's not very strong. Let's just go through
Yeah.
that. Why is a disc not like a jelly donut, and why should we stop saying this as therapists?
Well, I mean, so discs are dynamic. They do move around, and it depends on time of day, what you're doing, the activity you've done. But they're more of like what we'd call lattice structure. I'm not sure if many people know more what that is. It's essentially like a woven structure of like cartilage. If you took like the piece out off of like beef, right, that you can't cut through, you can't chew through, and you were to take those and weave those around, like a piece of meat or something like that, so where it's like all encompassed, like that's more of what a disc is like. Um, it's very strong and tough, and it becomes stronger the more you use your back and your spine. Like weightlifters, for example, typically have thicker discs than people that don't lift weights. And also we tend to see that there's a newer paper I cited at some point earlier this year in one of my posts that it seemed to be that with moderate levels of exercise, which include like what are under the World Health Organization guidelines of like that 150 to 300 minutes of activity a week, that people started to show regeneration of those like degenerative quote unquote changes that we'd see on an X-ray and an MRI. So it's like it's a living dynamic structure that adapts to, just back to basic physiology, um, adaptation to impose demands and all that good stuff that we learn in basic X-Phys.
And does it annoy you as much as it annoys me, the fact that people are still getting told this about the fact that they think that a disc is like a jelly donut?
I typically, because of the fact that, I mean, there are some patients that respond, like engineers seem to do really well with like a mechanical perspective, and that doesn't instill a mindset in them typically, of at least what I've seen, where they feel like things are fragile. But on a lot of people, that makes them concerned that means that inherently that structure is not strong. If it can easily be pushed out and pushed back in, that means that it could do different things, and that would potentially my back's out again.
Yeah, exactly. And it just creates a lot of fear and nocebo if you're saying something like that to a client that's going to have these negative beliefs, and they're going to pull back from exercise because they're fearful. So words are so important. And I've seen you mention that so many times on your social media. Words are so important because they have a massive influence on someone's long-term perception of their injury or their body. Now, on your podcast, you've actually talked about the flexing of your spine under load before. It's a
Yeah.
very, very controversial and nuanced topic, but let's just quickly
Mm-hmm.
dive into it. Your question that I gave you at the start was, is flexing your spine under load okay? You said, yes, it is. Why?
So, I mean, I even get back to like, I think we talked about the McGill, like Stuart McGill, like he's really known for biomechanics and everything. But the problem is actually, even like, I am not an original researcher like he is, and I have respect for some of the work he's done as far as papers, but not necessarily some of his opinions online, where he seems to diverge from what some of his own papers say in his opinion,
Yes.
where like we look at some of these papers and we're like, okay, so when somebody squats or deadlifts or does these typical movements that may be mimicked by stuff we do in day-to-day life, we like maximally flex our spine. So clearly it's meant to move in that way and be adaptive to that kind of thing. And it's not the end all be all reason why we develop pain.
So are you saying when we squat, deadlift, do a good morning, do a kettlebell swing, that you cannot keep your back in a perfectly flat position?
Yes. You can modify it.
Oh my God.
Yeah. You can modify it, but you can't actually prevent your spine from flexing.
Yeah, agreed. And the thing is with it as well, there are varying degrees of this, and I talk about it more as a neutral zone rather than a neutral position, because a neutral position could be very variable. At least a zone, you give the person a bit of a framework or an idea of how much they can kind of move depending on their anatomy and biomechanics, previous history, all this sort of stuff. The other thing that frustrates me a little bit about the McGill sort of mindset is the fact that a lot of the flexion-based loading studies that he kind of quotes are in dead pigs and these type of things. That annoys me because, you know, when they're bending a pig's back and forth when the pig's dead, there aren't any dynamic structures that are actually stabilizing the back, which is very, very different to what we're like when we're living. You know, we're moving around, we're picking things up, muscle tissues, we're doing a lot of work. There's passive structures as well as active structures. Just go through that. And are you in agreement with that in terms of the frustration that in him quoting these studies that they're relevant, and yes, they show that, you know, under specific conditions without the dynamic structures there, yes, it can get to the point where it injures the disc. But are you as frustrated with me that keeps coming up?
Yeah, I mean, because like, you know, like I think you and I would agree that like I tend to use a lot of the you could call them Lehman-isms, like Greg Lehman,
Yeah, me too. Yeah.
where it's like, you know, the qualities that tell us that somebody can adapt is that they're living and that they're human.
Yeah.
Because like if you're alive, it means that your tissues will adapt to demands. Like I had this conversation with a patient today. They were concerned about in their late 20s. They're like a drywall finisher. They need to lift. They're like, oh, I just got told I have degenerative disc disease. And so like I have them like practicing lifting stuff again because they have pain. And then I'm like, you know, like you're going to move through these positions and your body will adapt to it. Like lifting isn't bad for you. It's not going to wear you out. As like, you don't need to worry as much about how you're lifting things as long as you're consistent with how you lift things over time. And you do it that way every time because you're going to adapt in that position. And we can even look at research in athletes not even related to the spine, where they looked at strength training had like is like 70% reduction in risk of injury in the future with a strength and conditioning program compared to just like stretching and doing balance exercises. So it's like obviously as tissues become more resilient with that kind of stuff, they, you know, you can get in more awkward and different positions and sustain that and like tolerate it.
Yeah, really well answered, mate. Now, we're talking about the MRIs. The question was, is getting an MRI usually a bad idea with people that have back pain? Why is that the case? You said, yes, it is a bad idea, by the way.
Yeah. So typically, like for one of the things is that like when you develop back pain, typically there's most of the reasons why people might get back pain are not like modifiable like things. Like you can't necessarily change a lot of the reasons that may contribute to your first time getting it. And then we do know that when people have back pain, that they're more likely to get like start having chronic back pain and actual disability by actually getting more and more medical treatments and actually having imaging early on when it's not like they don't have signs that they should have imaging, which is majority of people with back pain. Like maybe 1 to 5% of people with back pain should actually have an image when they first present.
Yeah, and a lot of those people are, you know, exhibiting red flags.
Yeah, like they're having like, oh, I can't feel my butt when I wipe myself, or like
Yeah.
can't control my going to the bathroom, or like I was in a, you know, hit by a car, or somebody hit me in the back with like a blunt instrument or something like that, or you fell.
But if it's something that's just slowly come on, it's insidious onset, and it's just been flared up by, you know, sitting in the car or something like that,
Mm-hmm.
you would assume that that person probably does not need a scan or an MRI.
Yeah, and there's even arguments that within like red flags that you would wait and see depending on what they are and how extreme they are, because, for example, there's people that walk around with cauda equina that are asymptomatic and never have symptoms. Or I've had patients with cervical disc compression onto their spinal cord and no symptoms, no signal changes, no problems. And this one particular person, I ended up seeing them like a year or two later, after I saw them for their neck for like a different issue, and they were still fine. And they're like, yeah, I've not had any issues since I was here.
Yeah, the body is an amazing machine, and it has a beautiful ability to heal and cope with a lot of stress. So yeah, it is often amazing what a client can actually deal with and how the body can adapt. Now let's go into posture, mate. So you said, well, your answer to is there such thing as the perfect posture? You said no. Why?
So there's no like general perfect posture for people, and it tends to see that posture matters more when you actually are symptomatic, especially for back pain. For neck pain, there's more of an argument that like there's a minimal effect size on like different types of awkward postures and positions on like development of symptoms. But it tends to be that we're trying to tell people to move in a way that only people in pain typically move. Like one of them I picked up from Greg Lehman was like, he's like, if somebody sprained their ankle, and I guess a lot of other people have used it too. So if somebody sprained their ankle and they limp and that helps them to get around, we're not going to tell people that don't have ankle pain to walk around with a limp.
Yeah.
So, or like if my wrist hurt, I'm not going to like usually walk around with my fist clenched and then tell people, okay, so to avoid carpal tunnel or wrist pain, you're going to walk around with your fist clenched and not move your wrist at all.
Yeah.
Like we know that wouldn't be good.
Yeah, for sure. And I often put it like this to a client: your best posture is your next posture, because we're designed to move regularly. We're not supposed to, we're not really designed to stay in static positions for long periods. So, and this is a lot of the reason why people get soreness when they're sitting down for long periods at work, because they're just in a static position for a long period of time.
Mm-hmm.
This reminds me, actually, your fist analogy, what you were just describing then, I wanted to bring this up after you brought that up, is the fact that a lot of people think that they need to do core strengthening exercises when they have back pain. Can we go through why that is often not the case and why that is very outdated in terms of the old school transversus abdominis type of training?
Yeah, I mean, like pretty much like it's like we took something that's a very complex like system and tried to narrow it down to just like very specific things without actually having like good causality and like way to extrapolate that to actually show that it improves function. I think I've seen a few studies recently. I didn't read them, but I know I've seen them pop up through my feed and like people that I follow about like there was one that showed like doing transverse abdominis training like didn't actually have any carryover to like functional activities anyways. And then there's a review that I know Stephen May was part of it, and he's Australian, and I can't remember who else, where they pretty much found that like based on the whole body of evidence that they like we can't really recommend like core training for back pain. Like there's not enough of an effect size on like how it will make you feel or like how you'll function. And we tend to see that people with back pain already move more rigidly. So you're kind of asking them to just move more that way when we should probably have them work on actually moving more freely and relaxing those muscles.
Oh, I completely agree. And I've heard Peter O'Sullivan say this before, and I really like this analogy because some of the research suggests that people with back pain, as you said, move around more rigidly, and their core musculature and the muscles around their back are actually more active and turned on for more of the day. Now, that'd be much akin to you holding a fist, squeezing your fist all day and keeping that on. Imagine trying to do that and then trying to use your hand during the day. So what Peter has mentioned and why he's bringing that up is it's like your muscles are working all day. Those muscles really are designed to work when you need them. So for instance, you go to pick something up or you squat or something like that, rather than being quote unquote on and active, even while you're sitting or you're, lying down. They're active all the time. No wonder they're fatigued, and no wonder they feel tight.
Yep.
Have
Yeah,
you
that's, I
heard?
mean, that's like,
You've heard
yeah,
that
I've heard
before?
him talk about that. And it's like, if you think about a sprinter too, right? Like fast athletes are actually fast because they're able to turn on and off like muscles. So as they need like a muscle to take action or like, do something, they're able to turn it on, but then also be able to turn the muscles off that are in opposition to them. And they're able to do that very quickly and efficiently. Could you imagine if a sprinter tried to walk around with like a co-contraction of like they're contracting their hamstring and their quad the whole time? You wouldn't be very fast with that.
Yeah, I completely agree. And this is coming from someone like I've had my own back issues over the years, and it's pretty much the biggest thing I need to do is relax all of the muscle tissue around my back and my core, because I often just tense a little bit too much, and I try and stay a little bit too rigid. So as soon as I kind of take a little bit of a more relaxed approach, my back often feels a hell of a lot better because it's damn strong, but I just need to chill it out a little bit more when I'm doing day-to-day things.
Mm-hmm.
Now, let's go into one more question before we get onto the manual therapy debate, which you'll like.
Yeah.
The telehealth answer. So is telehealth physio just as effective as face-to-face physio? You found that quite difficult to answer. You did say it is just as effective, but why did you kind of have a little bit of a reservation, or you were sitting on the fence there a bit?
I think it really just depends on the person, right? Like people that are much more tech savvy seem to do better with it. And then people that tend to be like start off functionally better. So I think like your majority of people that are going to come in that like just by having them exercise, they would get better. Like they might get better no matter who they saw and what you do with them. Like they tend to do really well because they don't need as much like almost like cueing and like for you to be there to like touch them to like be like, oh well, try this strategy or like things like that, or just the in-person social aspect of it. And then it depends, right? Because there's some people that are also like extremely low functioning that I've treated that actually do well because they can keep their appointments more, because it's more convenient, because they'll like often not take care of like self-care, but because it's more convenient, they are more likely to show up to the appointment, and then also participate in their exercise program, which consistency matters. So I think, and then there's some research now that they've looked at with joint replacements where it's actually pretty effective, and just as effective as regular therapy.
Yeah, and I think that my experience with it is on point with that. I think people that are more tech savvy in the younger generation, I think, are often coping better with a telehealth. Yeah, I tend to agree. But I would say that it's a good thing, I think, for the physio profession, the fact that COVID's kind of happened, because it's forced people into thinking, all right, well, I'm going to have to do telehealth. And then all these manual therapists that rely on manual therapy are doing telehealth consultations, and some of their patients are getting better. And you're like, hang on, is that because you don't need to do manual therapy? And this segues into my next question.
Yeah.
So manual therapy, did you watch the debate between Cook and Meekins recently?
Yeah, I did. That was a good, I thought that was a good debate.
Yeah. What are your thoughts on manual therapy? Is it necessary? Because obviously Adam and Cook, or Meekins and Cook, they obviously discussed the fact that, specific versus non-specific manual therapy.
Mm.
It looks like you can do very non-specific manual therapy and get pretty much the same change or very similar change. What are your thoughts on that? And what are your thoughts on manual therapy in practice?
Yeah, look, I do use manual therapy quite a bit. Like, but it just depends on the patient. And I don't put a lot of stock into it where they like need me to like be the fixer. Usually, I use it as like a way of like modulating symptoms to help somebody with like consistency, with actually like coming, following through their program. They're like, oh yeah, it feels a bit nice. And I'm like, okay, well, you're also going to do this exercise that's going to just do the exact same thing that I just did, except you're going to be able to help yourself. All it tells me is that maybe we were on the right track with this exercise that I was going to give you anyways, because I can see that your symptoms changed and this exercise does the exact same thing.
So when you're, say, you've got a client for 30 minutes,
Mm-hmm.
and in terms of manual therapy, how much manual therapy of that 30 minutes would you do if you did do manual therapy in that session? Because I know you're much like me, a lot of sessions you
Yeah.
probably won't even do any manual therapy.
Yep. So like we have like an 8-minute rule for billing, and usually I don't even do enough to be able to like bill for it. And I just like lump it in with like therapeutic exercise and like other education and stuff that I do. Cause I don't just do, if I do manual too, where we're like actually like stopped in doing it, then I don't just sit there and stretch somebody. I usually like teach them something about it, like what I'm doing, what effects it has, like, you know, or something else in general, so that it's not like, oh, I'm just going to fix you with my hands.
Yeah, I completely agree. And I think I occasionally use it, and, especially early on, I may use it for, say, 5 minutes at the end of an appointment, something like that. But I use that time to continue to educate or make sure that they understand what I've given them in terms of their exercise prescription, all that sort of stuff. So we're on the same page rather than kind of like wasting the time. I'm not necessarily saying that manual therapy is a complete waste of time, because I think it still has its place in, a small proportion of clients and also a tiny proportion of each consult. But I think you can use it effectively rather than just doing it just for the sake of doing it. And I think a lot of therapists I'm going to go so far to say it's probably lazy, to say, all right, we're just going to do 15 minutes of manual therapy on this patient just at the end of the session because I can't be bothered.
Yeah. And I tend to use it more too, is like, it's nice of like leaning into contextual effects of manual therapy. Like it does have a large placebo effect. You're putting your hands on somebody might feel more comfortable, more relaxed. And then sometimes I notice that actually helps them to be more confident in exercise, even though I might have just done something on them that was very like basic and not like, because I'm not very specific at all when I do manual therapies.
And can we go through that quickly? Because we talked about the fact that therapists aren't very good at accurately palpating structures on the body. And now we're talking about doing non-specific manual therapy. So are you telling me that if you did, say, some manual therapy on a lumbar spine, if you just did some massage on one side that isn't too specific, say, for instance, a right side of back pain, you did some manual therapy, which is a bit of massage on the back versus specific joint mobilizations, we're going to get a similar effect?
Potentially. And in most people, you might see that. Like, I tend not to even try and figure out what segment I'm at. I go like, how does this feel for you? Is this like a segment that seems like it's painful or stiff? And then, okay, let me stretch that a little bit. And then, okay, do whatever activity now. And how's that feel now?
Yeah. So when we go back to what I was saying before, healthcare providers can't palpate things very accurately. Now, that isn't necessarily saying all physios and chiros and every sort of health profession out there, we're terrible at our job. What it's saying is anatomy is quite complex and it's hard to exactly palpate, the L4-5 facet joint, say, for instance. So I think that's been really empowering for me to read the research and look at that and think, okay, I don't have to be perfect.
Yep.
I don't have to know exactly where my hands are right now. But as long as I have a clear understanding of the general vicinity and I understand that this treatment that I'm about to do, if I do any manual therapy, it can be pretty non-specific and I'm going to get a similar change in terms of the nervous system change, the change in terms of the pain. So it is quite empowering in a way, the fact that you can be quite non-specific and still get a similar change. Would you agree?
Yeah. I mean, that's one of the things actually I liked about the McKenzie approach, was that like, it was empowering to like come out and then be like, what do you mean I can just have somebody do that and I put my hands on them and do this and then they'll feel better and we can get to doing exercise more frequently and they can actually do like the pain modulation stuff a lot of times on their own, and we just focus on consistently building better like health habits and addressing the other areas, because they feel confident, like they have control now over their symptoms more, and we can do more of, okay, let's exercise. Okay, well, how's your sleep? Oh, well, how are you feeling today? Like, different life things, get to know people more to find those, like, which areas do we need to specifically work more on?
Yeah, for sure. And when we're doing some of that manual therapy, a lot of the time, all we're doing is, as you said, there's the placebo effect, but we're giving the brain another signal, and we're giving
Mm-hmm.
the brain some more feedback. And it's much like this. I put this a lot of the time to my patients. If you had a little bit of back pain and then I came over and kicked you in the shin really hard, the back pain probably wouldn't be there anymore because now the shin hurts.
Yeah.
So there's this overriding effect and that puts it into sort of layman's terms for them, because it shows them that their brain is very powerful. And the other thing about it is you're always going to get these signals from your low back, your elbow, wherever it is. The brain sometimes gets to a point where it perceives those signals as something.
Yep.
If you
Yeah. I
if
do
you
one.
give it an overriding signal, well, the shin's going to hurt more than the back.
Yeah, I do one sometimes where I go to people like to like look at your thumb, look at your thumb, look at your thumb, and then I go, okay, try not to think about your thumb. And then they're like, they can't do it. And then I'll be like, okay, well, what's your pain like now? And they're like, oh, I forgot about that.
Yeah, that's a good
Or
one.
like, have you ever seen the movie Major Pain?
No, I haven't.
So it's comedy from the 90s. And in the beginning, there's a guy that's like been shot in the arm, and he's like, oh, my arm, my arm. And the guy comes up to him and he goes, let me see your hand. I'm gonna show you a little trick. And he goes, all right, ready for this? And then he breaks his finger. And he's like, oh, my finger, my finger. He's like, yeah, your arm doesn't hurt anymore.
Yeah, exactly. And that's often what I say to clients with the whole kick in the shin analogy. I really like that. Now, Jacob, I know that I've taken up enough of your time already, so thank you so much for coming on. Is there anything else you would like to discuss at the end of the podcast, or is there any advice you do have for any young physical therapists or physios out there?
The biggest one that I've been getting into now is like just not being afraid to, so in general, like not being afraid to challenge your biases. But I would say for the most part, it's like working on your communication. Like that's one of the things that I've worked more and more on, and like psychological things. Like I'm not saying we need to be psychologists, but I think they're very effective communicators. And you can learn a lot of things from stuff like just learning basic principles of like cognitive behavioral therapy and like motivational interviewing. And it's not because we're going to try and like change somebody's cognitions, but it teaches you almost how other people might think and how you can help to motivate them to be consistent enough and communicate through tough situations.
Yeah, I completely agree. I think that's one of the big things that I say to new grads or students when they reach out to me is focus on the communication.
Yeah.
Success leaves little crumbs, and psychologists are great at chatting to people and working through problems. And I think at the end of the day, we're kind of like mini psychologists. So I think that it is imperative to be good at communication. So it's great advice. Now, Jacob, thanks for your time, mate. It's
Yeah.
been an absolute pleasure. We should do this again soon. Where can all the listeners find you with, say, Instagram, website, all that sort of stuff?
Yeah. Oh, I actually got one more
Oh, you
like
got
little
another one.
crumb.
Yeah.
Yeah, because this was a conversation I had a lot more with a coworker recently. Was like, don't just try and emulate other people. Try and be yourself and figure out how you can take what you learn and make it work with your personality. Because a lot of times people will try to be like, they'll try and emulate someone that's like certain characteristics or whatever. Like I could never emulate like David Butler, right? He's very I don't know if flamboyant's the right word. Like I don't want to, like, he has very vibrant shirts and green glasses and things like that. Or like Lorimer Mosley is very charismatic, and so are some of these other people. But I just try and be myself just with the information that I learned from those people.
Yeah, again, that is great advice. And when you kind of let go of trying to be someone that you're not, especially as a clinician, it definitely empowering, because there's less pressure on this kind of facade that you're trying to create. I think it's really, really important to be yourself and communicate how you want to communicate, but at the same time, communicate in a way that's going to get the best result for that client and every client that walks in the door.
Yeah, it's easier, it's less forced, and people, I think, like you more when you're you're genuine.
Yeah, completely agree. Yeah, being genuine is so important. So where can the listeners find you, Jacob?
Yeah, so the best way to find me is on Instagram, and my handle's at strength and evidence _ physio.
His meme game is strong. I'm a huge fan. I always get a good laugh out of them. So keep up the good work, mate. I really love
Thanks.
your page. I've sent your stuff through to a lot of people over the years because I find it very amusing as a clinician that obviously practices very similar to you. But also there's a good deep-rooted sense of humor there, which is great.
Thanks. I appreciate that.
Now, this podcast is live on Apple Podcasts, Spotify, and Google Podcasts. Any final words, Jacob?
Thanks for having me on, and hopefully you guys will check out my page. And if you have questions, be sure to reach out to me, because that's something that's important to me too. Even though I might grow a following, I still really enjoy engaging with people and answering their questions.
For sure. And all the new grads out there and students, if you do have any questions, please reach out to Jacob or myself. We're always here to help because we were in your shoes not too long ago.
Yeah, for sure.
Cool. And as usual, guys, stay strong.